we will discuss statements with our guests. And these statements are easy for us. The statements come from all the conversations we had in the consultations, right? So these are provocative statements sometimes, really, expressions of what we've been struggling with. Statements, as I said, coming from the consultations, and we've been sharing those statements with our guests, and we're just asking our guests to reflect on those statements. Wafaa and I will try to moderate the session, and have some follow-up questions. First statement, we're going to invite Michel to be the first to respond to it, reflect on it. To meet the fast-track goals, UNAIDS estimated in 2014 that investment in HIV programs in low and middle-income countries would need to increase by about 1/3 by 2020. In 2015, however, donor investments for the HIV effort were 1 billion lower than the previous year. Domestic investments have risen, but not to the level required to meet the fast-track goals. How should countries prioritize their HIV spending if there are not enough funds available to provide a comprehensive package of treatment, prevention, and support services? All the panelists get like 3-4 minutes to respond. Then we'll hear from other panelists. If they want to come in, please, express your interest to join the conversation. Michel, you're the
Thank you very much, Peter. Let me just start by saying it's very important to start this day with remembering our friend Joep Lange. I think Joep Lange was for us a leader with a vision, and he was a caring person. One of his sentences, which linked us to what you were just saying, is that no life is worthless. And if we take from this perspective, we need a fully funded response. Without a fully funded response, we'll not be able to go to scale. Our report is showing clearly that the global solidarity have been able to produce a result, achievement. No one could have believed that we could reach 22 million people on treatment. But we are seeing a major gap. This report is saying to us that we need to close those gaps. We need to go faster. If we don't have 2.8 million people every year, will not be able to reach our 30 million people on 2020. So first, we need fully funded. We have a gap of almost $7 billion if we just link that to what has been accepted in the political declaration. We are seeing also that the bigger challenge which we will have is that if we have these stagnating resources, if we don't pay now, we'll pay more and more later. Because each accumulated lack of resources which give us a major challenge. Small cuts in countries like, for example, I can say, let me take Mozambique, because we are trying to do some work there. Our modeling is showing clearly that just 20% cut, Peter, will means that Mozambique need to double their health, I said health budget, to be able to continue to afford to pay for treatment costs and HIV response. So prioritization, key, being more effective, using resources which we have to maximize, but if we don't have fully funded response, will not be there.
Can I challenge you a little bit, Michel, because we talked this morning about more funding needed. Yes, we always say that, and we should say it, and we should repeat saying it, and we should fight for it, but countries need to make choices. Choices are made at country level. How do we support those choices?
I think
do the prioritization.
I think we started a long time ago saying that a country needs to know their epidemic, that we need to really make sure that we have a better tailored programs, which is focusing on each setting realities. And that's what we talk about location, population approach. And today we are seeing that when it's well tailor, when we are really investing where epidemic is, we can also reduce the resource which is needed, and we can have a maximum of impact. We can see that in many places today. So it's not just about increasing the volume of resources, but it's also being effective in terms of tailoring our response to reality of each epidemic. And we are seeing that with a key population, for example. We are seeing growing new infection there, but we are not seeing investment being tailored to really address specific places where we should be.
Thank you, Michel, for using the word priorities, which is very critical. I'm wondering, Maureen, first of all, thank you for being here. If you can talk a bit about, from the Kenyan perspective, and how are these priorities set in the context of limited resources, the priorities in terms of the HIV response and HIV-related services?
Thank you very much. In Kenya, we moved, it was quite a very significant shift, because initially the HIV response was well balanced. We had resources for commodities like treatment and diagnostics. We also had resources for civil society to do advocacy and to support the quality, to monitor quality of services and to ensure that people actually were accessing services, were retained, and were adhering to the services. And then came the drop in resources. And I remember one time when we were applying for a certain Global Fund grant, and a meeting was called with people living with HIV, and they were asked, if we were to give you your treatment or other support services, which one would you choose? That's quite a tricky question and they framed it, if you were to get your life-saving treatment and other services, which one would you prioritize? So it was quite a tricky position, and people living with HIV in the room said, no, we don't want to miss our life-saving ARVs. And so the response slowly became commoditized, and we were more focused on procuring treatment and other diagnostic commodities. But what we saw later after this is that we had a lot of drop-in centers that were supporting adherence, supporting stigma reduction, supporting human rights campaigns, closing down. And then the effect on it was also seen in the healthcare facilities, where some facilities reported drugs that were expiring, that were not being taken. They reported people that were not coming back for treatment follow-up. And also, we had to start campaigns such as ending stigma among adolescents, because the drop-in centers where they would have gone to had closed. We started also a campaign, I think last year or the year before, finding 17,000 women who had gone to the health facility for HIV testing during pregnancy, and they were not seen again a year later. So it means these 17,000 women did not get any services beyond testing positive for HIV. So we started the Finding Our Women campaign and such campaigns. And these are not just what we call campaigns or something to address the shortfalls, but it costed lives, and we had new infections that we would have averted. So that means it's important to balance both the medical and the non-biomedical interventions when responding to HIV.
Thank you. And Soumya, thank you for being here. And do you have a perspective on this from where you're at now at the WHO in terms of how to help assist countries as they try to make those very tough decisions that Maureen raised?
Yes, exactly. As Maureen was saying, I think, for every country, it has to be done individually based on their context, their epidemiology. And really the question that they're trying to ask is, within the given fiscal space that they have, what is the package of services that they could provide? And these should be evidence-based. They should be having the highest impact. They should be acceptable to the population, and they should be feasible to scale up. So I think the WHO is really stepping into this space in a big way, because we now have universal health coverage as our overarching goal, and everything else needs to fit in. I think we have to move away from the disease-specific vertical programs to really thinking about what is that essential package of services that needs to be delivered. And this, of course, includes not only treatment, but preventive services. We've seen that we're not meeting the prevention targets for HIV as well. So it also includes rehabilitation and palliation and so on. So what the WHO is doing now is to really try to put together all the evidence base that we have into a sort of menu of options. These are the essential health packages that should ideally be delivered, and starting with the levels of the health system, what can be delivered at the primary health care centers or even below that, and then what is it that needs referral to go to a district level hospital or perhaps to a tertiary center. And countries would then be able to, with discussion and with those criteria in mind, be able to put together a package of services, and then, of course, there's a detailed costing that's done. Side by side, of course, one needs to focus on things like the data systems, the logistics and supply chain, and being able to procure drugs. Many small countries face procurement challenges because they don't have the volumes to be able to bring down the prices. So we're trying to look at regional mechanisms where many small countries could agree to have a common regulatory framework and a common procurement, especially for drugs, for essential drugs that need to go into their health systems. So we need to think of ways of balancing what countries can do individually and what could be done at a regional level to support and expand them. Again, the health workforce is another good example. Recently, I was in the Central African Republic, and they have issues with all of these, the procurement systems for medicines and other health products. The health workforce has been sort of destroyed and decimated in many of these countries which have been under chronic conflict. And so you have to think of ways of rebuilding those health workforces. So I think it's a very tailored approach, and WHO is now going to provide that sort of consultation at a country by country level. But I just want to add a final point, which is the role and the importance of implementation science and implementation research. Michel was talking about the importance of data. I think every country really needs to know what is it that works best for them and what's the most cost-effective as well as high-impact intervention. So building in learning while you're doing, I think, is also a good message for countries. What works in country X is not necessarily the most optimal solution for country Y.
I think that's a very. I hope my mic is going to work in a minute. Yes, that's a very comprehensive approach. Quite an agenda, and I'm sure that it will also be interesting to hear from Debbie and Peter. Not now, but later. How you make that your efforts work in building those comprehensive systems that we're talking about already. I think we should go to the second question. I'm just keeping track of time a little bit, and I'm sure there are many opportunities to hear your opinions on this. Over to you, Wafaa, I think.
Sure. I think we'll start with this question for you, Peter. And thank you for being here as well. And so I'm going to paraphrase the question, but as we all know that overseas development assistance for health is largely guided by poverty assessments or the World Bank categorization of countries. And what's been happening most recently is that with good news in terms of advancing economies in many countries, as many of the countries, the poorest countries, are moving on to middle income status and advancing along that trajectory of development. However, that comes with a challenge, which is that obviously for funders in general and the Global Fund as well as others, that results in the tough decisions about withdrawing from specific countries, and particularly because we know that more than half of the world's poor live in these middle-income countries, and a large proportion of people living with HIV. So how do you tackle this dilemma of there being needs, particularly needs by key populations, disenfranchised populations in many of those countries, while at the same time you need to take into account that these countries are now transitioning to a higher development scale?
Well, to start with, it is true that the majority of people living with HIV are in middle-income countries, and it's also true that donors tend to focus most on poorer countries. And I completely agree that as a global community, we must remain committed to leaving no one behind. How do we reconcile the tensions? Well, the way the Global Fund approaches this is it doesn't just take the income level of a country. We start with the disease burden, and indeed, we don't just take the aggregate disease burden, but we adjust it to take account of the fact that key populations are often underestimated in scale, and that the disease burden within the key populations is often underestimated. So we do a sort of adjusted disease burden calculation. We've had a lot of discussions at the board and with partners about whether GNI per capita is the right measure, and obviously there's lots of different measures, and we set up the Equitable Access Initiative, working with partners to sort of look at this question. We eventually concluded actually that there isn't really a better measure than GNI. So what we are essentially trying to measure is both the burden of disease, taking account of concentrated epidemics, and we are also taking account of the ability to pay, an ability of a country to be able to pay for health services. And you have, in thinking now, what I do realize is that there are significant inequalities in some of the wealthier countries, and also ability to pay doesn't always translate into willingness to pay. Because of that, a lot of our work around transition and sustainability is focused on exactly that. It's on working with civil society to challenge and break down impediments to access to services, and working with governments and others on the sustainable financing challenges. And the reality is the Global Fund, if you sort of compare us to most organizations providing development assistance for health, we're in a lot more countries and a lot more middle-income countries than most. But we can't escape the tough trade-offs here. We have a limited resourcing envelope, and we have to make some trade-offs decisions. And we cannot entirely compensate for the governments of upper middle-income countries which decide not to provide the services they ought to be providing. And one has to be careful also when thinking about this, about the incentives we create. So if we had mechanisms that took account of inequalities and unwillingness to pay, would we be incentivizing governments? Would we be condoning inequality and that kind of unwillingness to provide services? And so what we try and do is focus primarily on disease burden and willingness to pay. We cannot escape the fact that that inevitably involves some tough trade-offs when we're in a situation when the total resource envelope doesn't meet the need.
Thanks, Peter. Well, let's hear, because you talked about it, this has been debated a lot in the Global Fund board, right? And Rico's here, he was part of those conversations. Rico, maybe you could reflect a bit on your perspective on, the choices that have been made, and also maybe, this is partly all about eligibility, right? I mean, are there alternatives? Should we, what's the perspective from the communities and civil society?
All right. I'm not sure if this is working. Is this...
Continue talking.
Okay.
There it is.
Thank you. So I think it's important to actually recognize that when we're talking about eligibility policy, the issue is in two dimensions. I think the first dimension is the political dimension, and the second dimension is the technical dimension. Now, the problem is that sometimes when we're discussing about the eligibility policy, we sort of mix these two dimensions, and it's becoming very, very muddy. We're having a technical discussion in a political space, or are we having a political discussion in a technical space? So it is important to actually recognize that, because if not, then we're going to continue getting confused on where we're going. And I think it's important to recognize that the political dimension of this conversation is that basically donors' commitments are winding down. At the same time, the commitment of some governments are never really reach at that level necessary to actually sustain their response to the epidemic. So I think it's important to recognize that that is the primary issue in terms of the eligibility discussion. It's resource constraint. It's not about the technicality, it's not about the GNI per capita or the disease burden itself, but it's more about whether we do have the resource that we need to actually end the epidemic. Because right now the eligibility policy is serving as sort of a donor's, it's an indicator of donors' appetite rather than a tool to actually understand where and what should we invest in terms of ending the epidemic. But it's necessary also to talk a little bit about the technical aspects of that, which is something that Peter already mentioned as well, which is around GNI per capita. And this is, GNI per capita is being used as the indicator as the metric for the economic capacity indicator, which, in my opinion, and some other civil society and community organization is of course a big mistake. The result of the economic equitable access initiatives is actually, yes, GNI per capita is the best, but not to be used alone as an economic capacity indicator. Yes, the Global Fund is using the disease burden metrics as well in combination of that, but as economic capacity indicators, GNI per capita is not enough. So I think there are a couple of ways in tackling that issue in particular. I think one way is that something that the Global Fund has been discussing, which is around, can we then try to, when countries reach certain level in their GNI per capita, can we try to do an additional analysis to actually confirm that they are upper middle income countries? Fiscal space analysis, or we're looking at their PPP indicators or something like that. So this is something that is already, the Secretariat and the board has been looking at. I think one way to mitigate the fluctuations on the GNI per capita is also because now the Global Fund is averaging the GNI per capita for 3 years, which is good in one way because it slows country to transition out, but it's also at the same time it slows country to transition back in as well. So it goes both ways. And I think something that the Global Fund has been starting to do for the last few years, and it's important, is to broaden the spectrum of how Global Fund engage with countries. And I think it's important. It's basically to make the eligibility policy sort of a non-binary. So it's not only either countries eligible or not eligible, but there's also a way to actually engage with countries that are ineligible, either through multi-country proposals or either through strategic initiatives. And this needs to be, the spectrum of models needs to be broadened up. But I'm going to, another way that we've been discussing as well in terms of how we can make eligibility policy works better, and this is my last point probably, is by reversing the two metrics. So right now, the economic capacity indicator is the primary metric. So after that, it's becoming an exclusionary criteria, because after that, the upper middle income countries needs to have certain disease burden. One idea is actually to convert that, so to look at the disease burden first and then the economic indicators instead. So those are ways to actually improve the current eligibility policy for Global Fund, but also for other financing institutions. But again, unless we actually address the issue around the political commitments of donors, the political commitments of the implementing governments, we're not going anywhere with the eligibility policy, because eligibility policy is just a reflection of the current appetites, really.
Thanks. I wanted to give Peter a minute to respond if he wants, because it was sort of the dialogue, but you don't have to. There will be other...
I would agree with the fundamental point, as Rico is saying, is that if the aggregate amount coming from donors and from domestic governments isn't enough, then ultimately you're going to have a mechanism which gives you some sort of prioritization, and that's inevitably going to be a suboptimal thing, because we aren't leaving no one behind if the aggregate is not enough. And the way the eligibility policy and allocation mechanism works is essentially trying to do that in a sensible way, and that's why it's a constant subject of debate and discussion among the board and the stakeholders of the Global Fund, because these are very difficult trade-offs.
About leaving no one behind, Wafaa. It's a segue into the next.
Yes, no, I was actually wondering, Ambassador Birx, Debbie, if you wanted to comment on how these tough decisions can be made so that we can reach the most people and also motivate countries to be able to, willing to support the funding for services within their countries, particularly at a time when their resources are constrained. And how do you conceptualize that as you think of the diversity of epidemics around the world?
Yeah, I think that's really the fundamental question to all of us every day. And I think we look at it a country-by-country piece, because I think in most of the cases of middle-income countries, except for South Africa, the issue is much more about the political will to address the epidemic that they have versus the epidemic they want to have. So the resources are not aligned with the epidemic that they have. And I think that's a very difficult thing to address then when you're there as more of a donor or a bilateral relationship or even a multilateral relationship. And so in many of the middle-income countries, and certainly some of the upper middle-income countries, there are the resources to comprehensively address the epidemic, but it's not the epidemic they want to address. And I think collectively, as a global community, I think we have to, 30 years in, start being very specific about what those countries are and really have a discussion about, it's not about leaving people behind, it's about governments' unwillingness to even recognize that the people exist within the country. And so I think to me, it's not usually a financial question. I think in the question of South Africa, it is a financial question, particularly in the relationship to the last survey and suggestion that we're getting close to 8 million people infected in South Africa. I mean, that's a collective need that we all have to address, and that's why we've increased our funding by $250 million to South Africa each year for the next 2 years to really create that surge potential so they can address the epidemic that they have, both with prevention, treatment, and community services. Just one quick thing on the community service piece. It's very interesting when we were discussing working with countries to a sustainable agreement, we had these partnership frameworks. And when money became tight, the first thing to go was the community health workers. And I think that was an illustration to us that we have to legitimize and create the framework that community health workers and the community piece are recognized within the healthcare delivery structure in a very clear way. And I think we're all working to that space now, but it's very interesting that if they're not recognized as professionals and critical to the process, they're easy to be left behind, and we have to make sure that that doesn't happen.
So it's more than country ownership, it's country responsibility in a way, and how to motivate this. And I'm sure that's something, Michel, that you think about all the time, and everybody on this panel thinks about all the time, is this perverse incentives and motivation and setting priorities. Maybe we'll move on to the next question, and this next question really is focusing on the universal health coverage. And as you're all well aware, many countries are moving towards or hoping to move towards universal health coverage to their populations. But also, I think, based on the work that was done in writing the report that emanated from a process over the past year or so, is that it's also been recognized that the HIV costs are substantial, and often HIV services are not included in the packages of services offered within the context of universal health coverage. So Soumya, you've had experiences in tackling some of these issues, both in your prior work in India and now at WHO. And the question is that what can we do to ensure that as countries are moving towards universal health coverage, that they incorporate HIV-related services for populations of people living with HIV, and maybe how to offer them models of care or packages of care that would be essential to include in universal health coverage elements in a specific country.
Thank you, Wafaa. Obviously, there isn't one answer to that or a very simple solution, but I think several things can be done. The first one, I think, is really involving people beyond the health sector or the health minister, and specifically involving the heads of state, finance ministers, and others, who have probably a much higher role or more say in setting financial policies in the country. Very often you have the health ministers on board wanting to do the right thing, but they're constrained when they go to their cabinet meeting. So, for example, one of the things that Dr. Tedros did before the World Health Assembly this year was to write to all the heads of states of all our 194 member states saying, we've signed up for the SDGs. We won't be able to get there unless we have universal health coverage. When you come to the World Health Assembly, could your country talk about 3 commitments that you're going to make to see that your citizens are able to? So, and that really brought out a wonderful response, and we had pledges made by different countries at the Assembly, but also many heads of state who wrote back, committing themselves. And I think this year we have a lot of opportunities. In the next 12 months, we will have 3 high-level UN meetings, one on NCDs, one on TB. Both of them will be side by side in September. And then next year, we have the UN high-level meeting on universal health coverage. This year is also 40 years of the Alma-Ata Declaration on Primary Health Care, and there's going to be a meeting in Kazakhstan, in Astana, end of October, to look at what's happened in 40 years, but also pledge for PHC 2.0 or PHC for the future, whatever we want to call it. So I think the emphasis on primary health care as the entry point to universal health coverage is extremely important, because unless we strengthen primary health care, we're not going to be able to achieve any of the goals. So I think we have a good entry point in that all countries have committed to the SDGs and therefore need to do things to make that happen. But what they need to know really is what are the most cost-effective ways, what are the best approaches to doing that. And this is where I think technical partners, WHO and other partners can really come in to provide the right kind of advice and support to countries as they are developing the packages. And as I said earlier, you need data on burden of disease, you need data on cost effectiveness of different interventions, and you also need data on feasibility, acceptability, and the practical aspects of scaling up interventions. So these have to be worked on. I think this is the time really to go into specifics and into details, and to ensure that while countries are developing, so at the same time you have countries developing the insurance packages and looking at different options and ways of financing these packages. And then you also have the package of services that will need to be delivered at different levels of the healthcare. So India, for example, is a good example of where the head of state's commitment to health made a huge difference. Specific commitment to TB, and a high-level committee was set up. Domestic finances for TB were increased, and a commitment made to actually prepone the date for TB elimination. But also a commitment to universal health coverage, targeting initially the 500 million people living, below the poverty line, or the poorer 500 million, through a public insurance system that would provide the basic package of health services. And of course, a big country like India, the health services are delivered through state governments, and therefore each state now needs to work out the details. And that's where the differences come in. So states in the south like Kerala, Tamil Nadu, or Karnataka have a huge burden of non-communicable diseases, where they've already brought down infant mortality to less than 10 or around 10 to 15, whereas states in the north, and each state in India is like a country, still need to focus on bringing down maternal child mortality, communicable diseases, and so on. So even within countries, you might have to have targeted approaches to the package of services and what exactly you're going to focus on. So I think it's not possible to do this at a global level, but once the commitment is there and the means are there, then I think we need the technical partners really to start working together much more, because we have to move away from the disease-focused single vertical programs, because you can also save resources if you start looking at how do you start sharing investments in health information systems, investments in infrastructure, in the clinics, investments in the health workforce. How can each program or each donor doing that really make sure that that is serving the health system as a whole and not serving only a particular disease?
So if I may take it from there, because you said it, I think, it's, in a way we're having the same old, horizontal vertical discussion, but in a new way, hopefully, with a new opportunity, because UHC might be an opportunity here. What we found in the consultations is that because the HIV response in many countries is funded so separately, one way or another. And we have two examples here, the Global Fund and PEPFAR, contributing to that, and that's, it was a blessing to the world. But now the question is, how do we link the two together? Right, the UHC political commitment, which is opening doors. We've seen that, for example, in Kenya. You refer to heads of state making a difference. Now we see in Kenya the hard work needs to be done. And the question now is, how can, I'm going to you, Peter, how can, for example, a global fund be helpful here? How can we make sure that, it's not easy to leave, for example, the funding for HIV behind, sorry for using that phrase in this context, because that's tempting. It's taken care of. Let's focus on the other stuff. And maybe Michel, but definitely Debbie, maybe you want to comment to this. How do we use UHC to get more sustainable funding? For example, Peter, funding mechanism. How do we build risk pools? Can the Global Fund make a difference here? The innovative financing work is helpful, maybe, but also there are way more opportunities, maybe. Your reflections.
Just a small, simple question.
Sorry.
Let me start with a quick observation. First, I think if we really want to end the HIV epidemic, and we want to do so in a sustainable way, then it has to be built into a broader effort on building health systems, UHC, and the underlying financing mechanisms for that. And HIV have to be part of those financing mechanisms. The second point I'd make, though, is we want to do that in a way that captures some of the strengths that the HIV response has demonstrated over the years, which is the intense focus on impact and results, the enormously intensive and active engagement of communities, and also the linkage of science, clinical practice, all within a really data-driven approach to decision-making and prioritization of resources. We want that same kind of focus in things that build the broader health system. At the Global Fund, we are actively working on multiple dimensions of that challenge. So, for example, on the financing side of it, we've been involved in supporting the community-based risk pooling mechanisms in Rwanda. I think Mark was mentioning those when I came in a little earlier this morning. We've also helped with the development of health insurance systems in places like Vietnam and the Dominican Republic. But then when you actually think about the programs themselves, there are a bunch of underlying platforms which we've put a lot of effort into through our strategic initiatives and things around supply chain, data platforms, community health workers, and so on, which aren't just disease-specific. These are clearly platform capabilities that support the health system as a whole. And I think going forward, there will be more and more opportunities to have programs that build logical clusters of activity, be it linking, well, we already have our HIV and TB programs very often linked, but HIV and HEP and different packages of programs that become sort of broader component parts of the service delivery as a whole. But I think all the time as we do this, we must, I'd go back to this, we must keep this very clear focus on being data-driven, results-focused, making sure what we're actually doing when we're deploying resources, that we know it's delivering impact.
Thanks. Maybe one more specific question, though. We haven't discussed in the Global Fund context often building risk pools, for example. Global Fund could be well positioned to step in when countries express an interest to build risk pools, to take, to guarantee some of the risks that are connected to it, right? Especially when you want to work on integration. Is that a role that you see for the Global Fund, or a broker role? I'm coming to Ambassador Birx too in a minute, asking about the role that PEPFAR could play.
I don't think we're a natural leader in doing that, because
who would be, Peter?
The most obvious leader in doing that, and they have an order of magnitude more resources and capability in this space, is the World Bank. But not just the World Bank. One of the things I would like to see is I'd like to see the other regional development banks, who often have very sort of tight focus and capability and knowledge of the individual markets. I'd like to see them more focused on building and supporting countries in building domestic health insurance systems, risk pooling mechanisms, and so on. And that hasn't happened much thus far. If you look at the portfolios and the spread of activity of your average regional development bank, its tiny single-digit percentage is on health. If we could shift that dial, then I think they are the natural owners of that. I'm very happy to encourage it. My personal background as a banker and a financier sort of positions me to be able to sort of talk about this stuff. But I'm also a believer that institutions need to focus on what their mandate is and what their core skill set is. And I think we can play a sort of encouraging and facilitating, and we can put some money to work in this arena, but we're not the natural owner of building capability around domestic health insurance systems.
Thank you. Ambassador Birx, maybe, since I promised to come back to you.
Yeah, I guess I look at it a little bit differently. We've invested probably $15 billion into the health system in low-resource countries. I think trying to put 20th century solutions into what is a very different problem today. We've put probably $5 billion into the supply chain, and we're having the same supply chain discussion. So clearly how we have done it, it's not just about the resources, it's how we have done it together and whether we need a different solution. But this sense that universal health care access and primary care is going to spontaneously occur, and that if you build it, they will come. I think we have a very clear evidence base that we have built it and they haven't come. And we have a very clear now understanding who's missing. And I think it's really got to be much more of a community shift where there's just a whole philosophical change of wellness and prevention, and healthy people are perceiving themselves to be healthy, see themselves in the healthcare delivery system. Because we have gotten all the sick people with HIV, or the most of them. It's going after the 50% now, who are well over 500 CD4s, are well under 35, and don't perceive themselves to be having a role in the healthcare delivery system, because we built a healthcare delivery system for pregnant women and children under 5. That's historically where we're coming from, and now we have to shift our really beginning somewhere, our education of young people or our education in schools, that the healthcare delivery system is there and there for them to prevent the NCDs rather than diagnose and treat the NCDs. So I think HIV offers a great opportunity to help support that shift. I'm sure Mark talked about, if we looked at every developed country, it all comes down to taxes and insurance schemes, and that the other pieces are nice, but maybe figuring out the taxation and insurance schemes for the countries in which we work, and there are groups working on that every day, and it's very often the bank, but our Department of Treasury also works with countries around that. So I think sometimes we talk about like these things don't exist. There's a very robust healthcare system in many of the places of sub-Saharan Africa that weren't there before. But the people who need to access it now don't see themselves in it. So either from stigma and discrimination and how the community has isolated, or just the fact that an 18 to 22-year-old doesn't see themselves as requiring interaction except when they're injured. So I think these words have to be translated into something that's very real on the ground, and it's not just a resource issue.
And in some ways, it's also, you're absolutely right. In a way, it's a transformation of how people think about wellness and illness. But there's another side, which is transformation of the health systems and the health delivery towards a very different way of delivery of services that's much more focused on wellness as well as prevention rather than treatment, so we have challenges on both ends, the recipients of the services as well as the providers of the services, and in a way, the transformation needs to happen on both ends to enable high-quality services. And I do feel that at least we hear it, and maybe Maureen can talk about it a bit, is that for recipients of care of HIV services, there's a great fear in sort of a dilution of the attention to, there's a fear that moving to more of a integration of HIV into primary care, and there may be a loss of the quality of the services and the comprehensiveness of the services. So I wonder if you want to comment on that.
Yeah, just a quick short comment is that some of our health facilities are not well established to take on the comprehensiveness that is needed to respond to HIV. And like, for example, in Kenya, when we have doctors strike, sometimes that go over 3 months, the HIV clinics continue operation. So people living with HIV rarely miss their treatment because of that. So if it's integrated, that's just one example, then we could have challenges when such things come. So integration is good, but I think we still need to work with our systems and do it a step at a time so that we don't lose the gains. So even as we integrate, we leave room for differentiated care models.
Maybe let's hear from Michel. You want to comment on this too? Because then it would be the full perspective.
Let me just, is working? Yes. Let me just piggyback on what you asked to Peter, and I think Debbie was also talking about. I think the danger is just to say that today we have universal health care, and let us move on. Universal health care is the ultimate goal for all of us. No one in this room can think 1 second that will work against universal health care. But we need to learn from our past experience. And HIV can bring a lot. You will never achieve universal health care if you don't have people-centered approach. That's what HIV brought in the debate. With activism with the communities, with a focus on a result like Peter was saying, but also engaging different model of delivery, service delivery approach. I remember working with, when we were talking about a community preparedness for treatment, when we're transferring competencies down, making sure that we can have a different approach to reach people where they are. That you will not be able to achieve universal health care if you don't have that. Secondly, how we engage private sector, how we manage to negotiate to make the price of medicine going down, to go to scale with servicing, mobilizing resources from outside. So I can go on, but those are issues we should not lose. But coming back to your point, community is central, from South Sudan to any place I went. If you go to Sierra Leone today, we have one doctor, I said, for 55,000 people. How you can really be dreaming that tomorrow you will give services to all those people if you don't change your paradigm, if you don't have a different paradigm which will focus on community health worker, transferring. Health system is important. But what I learned from my experience, a system for health is even more critical. Transferring competencies, making sure that we have early detection, then we have an information system which is going down on real time to respond to issues is central. But we don't have today mechanism, to be honest, which help us to finance properly community. Architecture which is there to make sure that fund can go down quickly, to support them, to make them effective, is not always there. So I want just to underline that one.
Thanks. Actually, I always hoped that the Global Fund would be that mechanism that allows us at least to work with communities and fund communities. But thanks for raising the point that we should talk about systems for health, which include community systems, right? Final comment, since everybody talked about UHC and the opportunity and the challenges, Rico. Short, but
right.
Yeah.
So very short, probably. But one thing that has been discussed, like among communities and civil society activists, is how. So what are we talking about when we're talking about integrating HIV into UHC in countries that criminalize key populations? And that's a difficult conversation that we have. And unless we can actually figure out what the type of service modalities that can be integrated, then we're basically talking about nothing. Because if countries still criminalize key populations, obviously services that are being provided are not going to be accessed. And we've seen that in the past, and we're probably going to see it again. And this is also to talk about what's the role of community and civil society organizations in the conversation around UHC. Because obviously these are, we can reach the unreachable, let's say. But so far at the country level, the conversation hasn't been really engaging that particular aspect of the response. So yeah, thanks.
Thanks so much. Let's move on with the next question. Statement. We should say that we've shared with the panelists, and this is a statement that we're going to ask first Ambassador Birx to respond to. Let's talk prevention more specifically. I'm going to read this a full statement. It's a long one, so that's why I'm going to read it, so that you have all the information that we put in front of Ambassador Birx, and then we take it from there. Some success has been achieved, obviously, in preventing HIV transmissions. New adult HIV infection rates declined by more than 20% in 75 countries. 57 countries between 2000 and 2015. However, more than 2 million people worldwide were newly affected with HIV last year. And as a result, the core 2020 fast-track prevention target to lower annual infections to 500,000 that year is off track by a wide margin. A quickly growing population in sub-Saharan Africa creates even more challenges. We talk about the young people here in controlling new infection rates. Yet, overall funding for HIV prevention has never reached the 25 mark estimated as needed by UNAIDS to meet the current targets. And the Global Fund, the GAC, the committee that oversees the grants, the approvals, pointed to the risk that funding for prevention is crowded out due to the success of treatment programs. How can epidemic control be reached without scaling up primary prevention? What will take it to make that happen? Well,
well, we have 25% of our funding in prevention, so we're already there. But I will say that was hard fought. I mean, we've done over 15 million circumcisions. We're the largest condom provider in most of the countries, and we launched DREAMS very much focused on preventing infections in young women. But this is really, when you look at where prevention has been most successful, it was prevention of mother-to-child transmission, because the healthcare delivery system recognized the importance of pregnant women. There is no, when you push young women, you push young men into how to get prevention information from their healthcare delivery system, it's zero. So no one is accessing prevention messages through their healthcare delivery system in general. So this is really a failure over our last decades of primary prevention within the healthcare delivery system. So if you look at, when you really talk about parallel systems, the biggest parallel system in the world is in HIV prevention, because it's all done at the community level, at the grassroots level, because in general, people have not felt welcomed to have those kind of conversations within the healthcare delivery system. And I think the long-term solution to make this cost-effective, it is eventually going to have to go there, or we're not going to be able to take these kind of prevention interventions at scale. What have we also learned in 30 years? Generic prevention interventions. I don't know what you meant by primary prevention, but if it's anything generic, that has not been, raises awareness, but does not result in people internalizing it or understanding that risk. And I think we have a long way to go to really understand risk behavior and our response to it in many of the countries where we work. I think, as Rico just discussed, it's very difficult to do prevention for key populations when the groups are highly criminalized. It's very hard to do that in a peer outreach situation. Some people have interpreted our peer navigators as peer encouragers of MSM behavior. I mean, this is the kind of issues that we're up against every day in country after country. So I think we have really very much, because of the call to action that UNAIDS put out there of the 25%, we've watched this very carefully and have moved resources very aggressively into preventing infections in key populations in young women. And I think it's as you described earlier, it's very different country within countries. It's different between countries. And I'm a little disappointed with saying 20% in 57 countries, because that doesn't mean anything to anyone when there are countries that have decreased incidence by more than 50 or 60% just in the last 2 years. So I don't want to have a discouraging number out there. I think we have to ask ourselves, how did certain countries get there and why are they there? And it's a combination of high-level political will, either by, as you discussed, either by the head of state or the first lady, saying that this is important. Young women are important to us. They're our future. We're going to have these discussions. That's as critical as resources. So there are countries who are achieving incredible gains. If you look at you only have to look at the difference between Ukraine and Russia and say to yourself, what happened? It's not lack of human resources, it's not lack of a health system. In fact, you could argue that Ukraine has been under more pressure within their health system in the last 5 years than probably any other country in the region with what they've had to face. Yet, they have a program right now that they will probably get to 90 in primary prevention in many of their MSM and people who inject drugs. So it's so much dependent on the country's willingness. And I want to really echo what Rico has said. I think it's very dangerous to be talking about individual identification and biometrics when the country has these behaviors criminalized. It's clear that they've acted on those laws. There's laws on the books and there's acting on the laws on the books. It's very difficult then to actually provide those kind of services when people are going to be identified. And so we still, we take data very seriously. We have data down to the site level. We cloak all of our key population site data and only publish that at the country level. We do that because there's still not the ability to provide prevention, primary prevention, and certainly the interventions that key populations need. And if you look across all of the achievements from the recent Book of Miles to Go, the biggest gaps are in key population concentrated epidemics. It's not a lack of resources. Just go back to Russia and Ukraine.
It's an excellent example. Maybe, Maureen, in terms of a priority population, so apart from key populations, we're obviously reaching and enabling them to get the prevention and services and the care services they need is of paramount importance. Addressing girls and young women is another priority population, particularly in sub-Saharan Africa. And, what are your thoughts in terms of novel ways or innovations that you can share in terms of trying to reach and engage this population in both testing, prevention, and treatment?
Thank you very much. I think I'll echo what Ambassador Birx has said around healthcare delivery systems and HIV prevention. And some of our healthcare delivery systems are completely overwhelmed with treating sick people who need life-saving interventions, that it's difficult for someone who is healthy to walk in seeking information on HIV prevention or other prevention services because of the long queues and the prioritization of people who are already very sick. So these are interventions that need to be out of the healthcare facility. And we have seen an increase in those with the DREAMS initiative and with the now catalytic funding from the Global Fund for Adolescent Girls and Young Women, that community services have begun targeting adolescent girls and reaching out for HIV prevention. And we have seen non-medical interventions that are needed. So it means we are looking into understanding their needs, their vulnerabilities, and addressing those, such as keeping girls in school. It's not a health intervention, but it significantly contributes to reducing HIV infections. And also, in this context, there's one gap that we have missed, which is the context in which they live. In the communities we come from, most people, for young women 14 to 25, are probably living with their parents or guardians. And so sometimes when we want to say we want them in their own space and we don't include the people who can support them to be adherent or even to access these services, then we miss that link. So there's need also we have started seeing successes with the DREAMS initiative and the Global Fund Adolescent Girls Program, but we need more in terms of reaching out to the environments in which the young women and girls come from, with the support, the kind of support they get from their parents and guardians. Some of them would tell you, oh no, don't give my daughter PrEP, she can't have sex, yet the girl has already said they're sexually active. So having those honest conversations with the people who are in charge of the adolescent girls and young women at home or in the environments where they come from, in their learning institutions, will be a step further to reducing the new infections. So it's just a matter of understanding their context, understanding their vulnerability, and tailoring the programs within their needs.
It sounds like also taking this multidimensional approach of biomedical, behavioral, also some structural interventions like schooling and so on, and job skills and life skills as well.
Yeah, it's all the three, the biomedical, the structural, and the behavioral interventions, all combined.
Well, I'm going to move on to another question, but maybe start with you again, Maureen, and then we can get inputs from the other panelists. And I think there's a lot of excitement in the HIV world now with this concept of differentiated service delivery and moving services into the community and trusting recipients of care to manage their own health, and that in a way reminds us of the important role of the community, and where now a lot of these services are moving and need to move, both for prevention as well as for treatment. So that adds to the value of, demonstrates again the value of community support groups and community-delivered services. So you've highlighted the issue of the danger of withdrawal of support of these services. Can you think of concrete ways in which community organizations, but also community health workers and others who deliver services in the community can be enhanced?
Yeah, I think our delegation has been struggling with the fact that countries are struggling to understand community system strengthening. And for example, Global Fund has defined and has a very clear document on community system strengthening, but we still have countries struggling. And this has been reduced in most contexts into providing some stipend to community health workers to collect data and take to the health facilities. But we believe that this goes beyond just collecting health data. We have to improve on quality of services, ensure the hard-to-reach populations have been reached, and these are the ones we haven't reached yet. The ones we are reaching are the easy to reach. So those low-hanging fruits, we're already there. So reaching out to the hard ones, we need now to reach out to the communities through institutional strengthening of community-based organization, creating safe spaces within communities where key populations and people living with HIV can access services. We had a challenge in especially men accessing HIV testing and treatment services. But with the introduction of self-testing, we have seen more men uptaking the self-testing services. But then now the gap remains linking them to the second 90 and the third 90. And we can't do that if we don't reach them within their safe spaces, in their conducive environment, and that is now through the community system strengthening. We can't do that in the normal health facilities, especially in areas where we have a lot of women and children, and they have to queue a whole day in the midst of women and children. So we need these interventions differentiated, and they can better happen at the community space. We have also had challenges of people saying, we cannot measure what you're doing, can you quantify what you've been doing, and those challenges that are coming with funding of community-based organizations. But we also know that we have systems of measuring impact that is found at the community, and also measuring output. So we just need to strengthen community monitoring systems, and this needs investments. So we come back to resources and ensuring that the resources are distributed equally, taking to effect that the community response is also very, very important. Finally, in terms of ensuring that no one is left behind, we must continue doing advocacy. We must continue addressing human rights violations. We must continue addressing policies and laws that criminalize people living with HIV and key affected populations, and those can better be done by community-based organizations. So it is fund, strengthen the systems. Thank you.
Yeah, thanks, Maureen. Because also to broaden it up a little bit, right? Because we shouldn't we shouldn't think about service delivery only in terms of prevention and treatment, but it's also the whole advocacy component. And if you don't have an organized civil society, you don't have that. Michel, Ambassador Birx talked about it. You talked about it. I think Peter talked about it already. You mentioned the role of communities in the service delivery and in terms of expanding our also capacity. I think you mentioned it this morning already, Michel. You've been fighting for this for years. UNAIDS set the bar. What in essence, what do you think is, what needs to be done? What needs to change so that we can, have a more serious discussion?
I think, honestly, we are reaching a level where we are seeing the limit of a traditional government-led service delivery system. Because in AIDS response today, if you want to reach those communities we're talking about, if you want to be really able to go down, to be able to give services to people who inject the drugs, to give services to men who have sex with men, sex worker, all those groups who are left behind, I believe, Peter, and you know that, we need a different paradigm of service delivery. And that is what we have been experiencing for years, is community-driven approach which will lead us there. But what I'm seeing is, at the same time, I'm seeing today a shrinking space for our NGOs, our communities, who are not anymore capable to deliver those services because their funding is also going down. So first, I personally feel that we need to really think about mechanism. I know we are working with Debbie on many of those issues, and also with a Global Fund, how we find a more flexible way to really transfer resources to those structures which are helping us to not to just deliver, like you said, services, but also remove barriers. All the barriers we're talking about, those legal barriers, promoting different models of prevention, reaching those men who are not reached today with our services, making sure that also we can have a different type of dialogue which will bring integration. We are talking about, of course, taking AIDS out of isolation. We can do it strategically. We didn't talk about TB, HIV. It's so important. We know that Debbie can talk along, Wafaa also, and that if we don't really approach that, we will never reduce mortality on co-infection. We know that cervical cancer and HIV, we can work in different ways, but all those will never happen with our just traditional approach of service delivery. So that's why I am convinced this community need to be receiving more resources and working more strategically to reinforce the interface between the last provider of government services and community.
Thank you. I think we're going to move on to the last question and modify the format a bit. We're going to ask we're going to ask all of the panelists to respond to the last question. And so the question is, what would you say is the only one, you have a choice of one, major obstacle that we face in building sustainable, effective, long-term global HIV response? And let's start, everyone has to pick one. So we'll start with you, Peter.
Right, so I had the maximum time to prepare the answer to this question, obviously. What's the single long term? I think the most important thing we need is actually the commitment and the belief that we can end the epidemic. And if we actually anchor ourselves around that as an ambition, and then say, and we're going to do the things that need to be done to make it happen, then I think we have a different kind of momentum. The problem I think we have is we don't have that commitment. We have it in some places, but it's very patchy. And actually, we don't really have that belief. We have a lot of people who don't quite believe it can be done. So I think if we could get that and get collectively as a global community to that, it would power things. Of course, there are lots of difficult challenges and trade-offs along the way, but at least then you have an overarching direction.
Okay, great. That's one major obstacle. How about Soumya? What's the one major obstacle?
I actually agree with what Peter says, but I would say that, when we're thinking about sustainability, then I would say that we need to think about not just HIV, but think really about the health of the population of that country. How does a country think about a population that's healthy? And that includes now in many countries a huge burden of non-communicable diseases. And as we were discussing about, how do you improve community-based systems for healthcare delivery, the very same thing is true for non-communicable diseases as for HIV, because things like hypertension, diabetes are all chronic diseases. You need to take lifelong treatment. And more people are dying of the complications of these diseases. So I think really for a government, it's to think about how do you keep your population healthy? What's the sustainable way of doing that? And what kind of things do you need to invest in terms of prevention, in terms of policies outside the health sector as well as within the health sector, in terms of long-term financing, and in terms of what kind of packages of services that you need to deliver and what you need to do that health workforce and other kinds of systems, the supply chains and so on. So I think that's the only sustainable way of looking even at the global HIV response.
Okay, Michel, what's your one obstacle?
Political will. I personally feel when we were here 20 years ago in Amsterdam, South Africa was the worst experience. We're all outside here talking about denialism, HIV is not transmitting, giving AIDS. That was the debate here. And today, with all we can say, South Africa is one, with all the problems we still have, is one of the best example we have today. 4.3 million people on treatment, a reduction on new infection, coverage on mother-to-child transmission from 70,000 babies born per year to less than 3,000. So I think political will is important.
Okay, Maureen.
Beyond what has been mentioned, I think I will talk of data, improving the quality of data and using it to make decisions.
Great, thank you. Debbie.
To me, it's really urgency. Somewhere along the line, with all the discussion, we put HIV back like it's a regular disease. It's still 100% fatal without a cure or a vaccine. And the only thing that stands between this and that is us and our prevention and our treatment. And there's no other disease, not even Ebola, that's 100% fatal. And I think somehow we accept 1.5 million new diseases in HIV and not realizing that's 100% fatal disease. And I think we've kind of lost that in grouping it with everything else. We have forgotten that it really is different, and we should still have that urgency to bring every action that we have to bear to change this. I mean, we have to believe it's controllable. If we didn't, we would be very depressed right now. So I believe it is, but it should be everybody, all hands on deck, and we shouldn't be diluting our energy at this moment because it is still 100% fatal disease without our interventions.
Thank you. Rico, what about from your perspective?
Right. So I think, so I won't repeat what others have been saying, but I think one of the major obstacles in building this is because I don't think anyone is 100% sure what sustainable and long-term global HIV response looks like. We don't have any blueprint. We've never seen that before. We were just starting to think about that like 5 years ago or something like that. So we're still struggling in terms of understanding. Yes, we know that it needs to be sustainable, it needs to be long-term, but what does that look like? I mean, nobody knows. And I think, political will is very important in recognition that we're still struggling and we're still learning. I think there's a great need for us to acknowledge that we are still trying to build this ship, but also to come up with a strategy in terms of what happens if we fail. I think that's really important to actually do that. For example, right now, we can't really say, we leave no one behind to key population in Serbia or key population in Romania, because we did left them behind. We need a safety net strategy here. So I think this is one of the major obstacles that we have, and this is how we actually mitigate that, by acknowledging it, but also coming up with a plan to really answer that question: what happens when we fail? What do we need to do when we fail? Thanks.
Yeah, there's a little smile on our faces, because if you add this up, right, you have the Amsterdam Statement. I thought this was a wonderful summary of critical elements in thinking about the future response. Thank you so much to the panel. That's what I wanted to say, and actually I think they deserve an applause for their contribution. Right? Thank you.
And thank you to the audience as well. Thank you. Have a good day.
Some of our guests, our guests want to leave, but maybe it's nice. Can we get the feedback from the room up, please? That you have a look at some of the comments that were made during your intervention. No, your presentations. What was it? Answers to questions. How to increase political commitment back. We talked about it. International community should listen to countries. Dibble. Similarly, countries should listen to partners. I think it's quoting Mark, maybe. We can increase and support innovation by countries with clearer toolkit and financial models. John, we have regular drug shortages. If I start treatment with 800 T cells, is that practical? Important question, one of the struggles at country level all the time, right? Will the Global Fund pay for advocacy in countries who are unwilling to protect key populations? There's more, right? I think if you scroll down, just a taste of what the room is giving us back. What does ending the epidemic really mean? Rico talked about it.
Okay.
I'm not going to read all of them.
I think it highlights some of the issues that actually came up in the conversation. So this is very, very helpful. So thank you for your inputs.